We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, thank you for tuning in to another episode of A Pinch of Salt, a podcast by ERA. My name is Andrej Kubana. I'm a nephrologist from Slovenia, and this episode is a real treat as far as I'm concerned. The topic is patient-reported outcomes in clinical practice. Now, admittedly, at first glance, this topic doesn't seem incredibly exciting. However, I honestly believe this might be one of the most important things we need to talk about, particularly in the context of working with patients with kidney failure. In medical school, we all learn how to see medicine through the lens of a physician, which is an important perspective, certainly, but not the only one. At the end of the day, what patients want, expect, hope, and yearn for should be as important as what we think is important. There's a nice slogan that has sprung up from various patients' organizations lately that I'm aware of that describes this attitude: nothing about us without us. And I completely agree. Here to talk about this is Dr. Paul Cockwell. Dr. Cockwell is a consultant physician and nephrologist at the Queen Elizabeth Hospital, University Hospitals Birmingham, and a professor of nephrology at the University of Birmingham. He also has worked on this extensively and consistently. I think it's fair to call him a champion of this topic. So, Paul, thank you for being here, and welcome to A Pinch of Salt.
Thank you very much, Andre. It's a great pleasure to be asked to do this with you today. Thank you.
Okay, so let's just go straight to the first question. Let's try to demystify this phrase. So what does patient-centered outcomes actually mean in kidney care, and how do they differ from the outcomes that we traditionally measure?
So conventionally, we're using the terms patient-reported outcomes and patient-reported outcome measures. So in short, a patient-reported outcome measure is a tool which allows you to directly capture what's important to the patient. It's what's important to the patient without the prism of our biases as clinicians, because as clinicians, we all recognize that we sit there with a patient in a consultation setting and provide the patient very often with a leading question that takes them in the direction in which we think the consultation needs to go. Whereas patient-reported outcome measures are built in a way that allows the patient to identify what's specifically important to them, and to do that outside the pressure of a consultation itself. So ideally, a patient-reported outcome measurement set, the patient should be given the opportunity to produce that and provide that in their own time with a platform that works best for them, to be assisted where they may have challenges in terms of their own literacy or numeracy. And then that then is used as the platform for clinical decision making, as opposed to our platforms, likes of yourself and myself, Andre, where we'll look at the estimated glomerular filtration rate or the phosphate or the urea reduction ratio and focus on addressing that rather than stepping back and assessing with the patient what's directly of importance to them. So that would be my overview summary of it. Clearly, there is a lot of detail in there. And one of the challenges in that detail is that as kidney specialists, be we doctors or dietitians or nurse specialists, we must talk as a global multi-professional team when we're dealing with patients. As kidney specialists, we're very empiric creatures. We focus very specifically on measurement, and we have to reframe that measurement as something that's truly important to the patient. We can measure estimated glomerular filtration rate, that's fine. But how do we quantify fatigue? How do we quantify itching? How do we quantify sleep disturbance, pain? And how do we use that as the starting point? And patient-reported outcome measures provide that for us. That may be a good framework for us as healthcare professionals to get into this, because one of the challenges is that because we're constructed such that we rely on measurement, using the patient-reported outcome measurements themselves as our starting measurement, which we can then map through to how we support the patient in terms of the interventions that may be of most value to them, seen through the prism of their symptoms.
Yeah, yeah. So you've pointed out a very key thing that we want to answer at this podcast, at least address, is how do we do this? I just wanted to, before we go into that, I wanted to say a personal story. I think the first time I realized how we're not on the same page with the patients all the time was when I was a resident and I was doing rounds with my consultant. And the patient was talking about the pain that she had, and the consultant was patiently trying to explain what we're doing to trying to figure out what that pain is. And then we left without even addressing what we could do for the pain itself. So I think we're so hardwired to understand symptoms as clues to a diagnosis that we sometimes forget that we're also meant to try to correct them at least. And so, because we're not really, I mean, I know I'm guilty of that for sure on several occasions, undoubtedly. So how do we approach this from the patient's perspective so that we don't miss out on what is important to them? How would you, if you start thinking about this, how would you suggest that we change our rounds the next time we go see our patients?
Great question, Andre. And the reality is that we're not using these measurements in our routine clinical practice. There are tools that we have in our clinical, as clinicians, that we use in terms of framing a consultation, framing an interaction with a patient, which could include opening questions that put the patient in the right place for them to be able to give an answer that is important to them, motivational interviewing, and so forth. There are various tools and techniques one can use within the consultation itself. But patient-reported outcome measures sit outside that, and they're measurement framework. So people will be familiar, listeners will be familiar with patient-reported outcome measures. EQ5D, for example, is a patient-reported outcome measure. It's the most widely used generic measure that covers 5 dimensions, some of which are truly important to people with kidney disease and other long-term conditions. And then when you come down into the kidney setting, you've got kidney-specific instruments such as KD-QoL 36, for example, which has been much used and is a validated tool that's mainly used in research practice. And then there are a number of other tools that have been developed and are out there in the public domain that can be used. But the gap is, how do you take this and how do you bring it into implementation? And the challenges in this at the starting point is what are the platforms and what are the tools, or the tool that you then present on that platform, and then how do you bring it through in a credible way for a patient and for the clinicians who are working with that particular patient. And one of the exciting developments in this current period of time is a move from these very heavy current questionnaires, which have got multiple questions in a range of domains, where one is often asking the patient to quantify against that, to an approach called multidimensional computer adaptive testing. And that's an approach where you develop a very clean patient-reported outcome measurement set, but specific for the individual patient. How does that work? Well, it works such that the patient is given a simple set of introductory questions. For example, they may be asked about the setting of kidney failure requiring kidney replacement therapy. You may ask a patient about fatigue, about pain, about itch, about sleep, about breathlessness. And those starting questions, the patient can quantify if the patient identifies any of those areas as an area in which they've got a particular challenge, they can quantify that. And dependent upon how the quantification maps, you're then taken into secondary questions, which allows a framework which firstly is fast. So you can do a multidimensional computer adaptive test, even for complicated long-term conditions in around 5 minutes. So you can see a patient as a patient comes in, perhaps in a clinic setting. They come into an outpatient area that they may be given a tablet, or they may go into a booth, or they may, if they're not literate, have the support of a health support worker to be able to work through a short adaptive questionnaire, which then can identify what's truly important for that individual patient at that time from a symptom perspective. And that then frames the consultation. Now, if you take a step back from that, and if you look at true framing of it, what you ultimately are looking at are people able to report from their home setting, where they may be able to report on a platform. They may be able to do it via a voice activating system. They may be able to do it at a fixed time point, monthly or weekly, or they may be able to do it if they think there's a change in their symptom burden. And it may be that there will be changes in symptom burden that we as clinicians would want to have a direct alert into us. So if, for example, you've got somebody with advanced chronic kidney disease who's progressing towards kidney failure that may require kidney replacement therapy, and we know that for commencing kidney replacement therapy, it should be much more focused on symptom burden rather than the measurements of EGFR, urea, whatever. In that setting, it may be that it's the patient developing nausea or breathlessness, which of course, you're not waiting. The patient's coming in 6 weeks, we'll see them then. We get the report when the patient develops the symptoms. So there's something very practical about it, but also how do you comb those big tools that are currently very burdensome down into a framework that's very specific for that particular patient and can be framed into a standard consultation time.
Yeah.
Does that make sense?
Well, it absolutely makes sense. I mean, I think you address something that is problematic in the field, and that is the cumbersome, if I might say, questionnaires. Not all of them are. But there are many problems with them. They take time, and particularly if you're not in an English-speaking country, then you are meant to translate them and validate them, and you don't know how to do that. And then if you have a specific group of patients, for example, I work a lot with kidney stone patients. In that field, it's very difficult, actually. There's no standard way, I would say, to assess outcome. What is the outcome? You don't have a stone in 20 years on a CT, or is it you don't have pain anymore, or is it you don't pass stones? You want to quantify it at least by yourself, but you don't know how to do it. So I guess you have to find a way in your own practice setting to possibly maybe even improvise. So how would you comment on that? I mean, one more thing is that when I talked about sleep problems with Dr. Unruh, and sleep obviously is terrible. I mean, if you don't sleep, it's a terrible situation. And I asked him which questionnaire would he suggest, and he said, well, I would suggest that you ask the patient whether he sleeps well or not. And then you go from there. So how would you comment on that, on this, sometimes difficult way to decide what to actually do, what to take into your hands?
So the starting point for us, you make a fantastic point, Andre, and we have to openly recognize at the start that there are major inequalities that are currently developing as a consequence of the focus on things being done in the English language without adjustments so that you develop tools with a population of people who speak English as a first language, and then there's an assumption that those tools can be transferred across. And that needs substantial work. There are ways of doing it that can be relatively lean and clean in terms of how you bring groups of patients and healthcare professionals together to design tools in a native language that may use a tool that's already been developed and has been validated in another language. Of course, we're usually talking about English there. But the starting point, I think, for us as healthcare professionals is to use the SONG framework, which looks at outcomes, suggests frameworks for outcomes that are both patient-facing and clinical outcome-facing. And the SONG framework is in place for most areas of kidney disease now. So if you're looking at hemodialysis, for example, there's patient-reported outcomes and there's clinical reported outcomes, and the patient-reported outcomes within the SONG framework, in whatever area of practice you're in, are a good starting point to think about how one then brings the measurements into place. So that's the first thing to do. The second thing to do is to look at the current frameworks that are out there and to identify which of those may be best placed for use in local practice. Now, that in itself is challenging because there are new measurement outcome tools coming through in this current period of time. I'll talk a little bit about this in a moment. But then to step back and to think more globally as to what patients are really reporting, and then how do you bring that so that your clinical team is all cited on that, firstly, but crucially, you have patients in the mix there from the start so that your patient groups are inputted into your local services in terms of how you use these. Now, the challenge here, Andre, isn't the patient and isn't the enthusiasts. So actually, the challenge is that yourself, myself, and other colleagues who've seen this area developing and are committed to it, we have to bring a large group of people with us who are clinical colleagues, many of whom, understandably, often for good reasons, are skeptical about layering in an additional, what they would see as an additional complexity, time commitment if we're integrating patient-reported outcome measurements. But understanding what the framework is from a patient perspective, going back to the core literature, and I'm not going to talk too much about the work that we've done in the UK, but I will signpost one thing, that we've had fairly substantial funding, both out of the NIHR and also Kidney Research UK, into a number of groups within the UK. We've tried to bring that together into a single framework. But one of the things that we did when we got funded from Kidney Research UK is we did a systematic review of all the patient-reported outcomes that are currently known, and that was published in 2022 in PLOS Med. And I would encourage people to look at that as a starting point, because that does provide a real readout of the impact of symptoms in specific areas. So it takes everything that's been published in terms of symptom burden, be it dialysis, transplantation, chronic kidney disease, and presents that in a way in which the individual domains that a patient will report against is quantified against what the baseline, and understanding that within your team and getting that conversation and dialogue going. And then how do you then bring that through into a patient-reported outcome measurement. We've tried to do that. We've developed something called the kidney symptom burden, which was published fairly recently in the Clinical Kidney Journal, which is based upon taking the symptoms and working with patients to then produce an item bank. So an item bank will be the individual symptoms that are of importance to a patient that they can report against, worded in a way that they recognize and can report against and can be quantified, it can be measured, which can then be put into simpler questionnaire structures that are shorter. So look at something like the kidney symptom burden and think about how that then could potentially be implemented into clinical practice, and then think about what actually are the platforms. How are you going to do this, and how do you do it in a scaled way? So
Yeah.
we you know, as kidney specialists, we like pushing on with evidence fast, but this is here to stay. And the way to do it is to start it small, introduce it into a single component of your service where you've got enthusiasts, where you can have the multi-professional team and the doctors working with the multi-professional team, particularly working with groups of engaged patients in a particular area, and think about, well, how do I bring it into my dialysis unit? Is there something about doing the measurements on a tablet for patients who are going on to the machine? There may be some complexities with that if they're receiving hemodialysis. And then how do, and this is the really crucial point with this stuff, we have to be seen to be taking the outcome measure that the patient provides us with and doing something about it.
Yeah.
And
Yeah. That's important.
that's crucial. That
That's
description
crucially important. Yeah.
is crucial. And because if we don't do that, we lose credibility. It's just
Yeah.
another thing we're asking for. Well, I told them
Exactly.
that, and they ain't done anything about it. So,
So
but
I'm really
I look at
happy.
the tool. Yeah.
I'm really happy that you mentioned a couple of things that we can check out if we're beginners. So the song framework, the review in 2022, the Clinical Kidney Journal paper on symptom burden. And one thing that stuck in my mind also was working with the patient, asking the patient. I mean, of course, if you're looking for a patient-reported outcome, the most logical thing would be to ask the patient, what would you consider an improvement of your life? What would you consider to be a success? That's probably what we're looking for. And so if you don't include patient in that conversation, you probably won't get a patient centered or patient important outcome. And the third thing that you haven't mentioned, but I thought about it when you were talking, is that including nurses in this is also very important, because nurses usually have a good sense of when the patient is doing well and when he or she is not, and what that difference actually is. I'll just convey a little short story about how in my dialysis clinic they started to do intradialysis workouts. They started to do physical work, the bicycling and all that. And I asked the head nurse of our dialysis unit, so what do you think? Is this worth doing? Does this do anything? And she said, well, I noticed that the women started to use more makeup and that they were starting to wear better clothes, and men started to talk with each other much more than they used to. And I immediately understood that that's success, although you would never find that in a paper, I guess. But yeah, so that's the kind of thing that you're looking for, I guess, as well.
Yeah, that's a really great one, Andre. And there's something in there for us in terms of how can we capture it from a healthcare professional perspective, and also capture those. These are complex systems, aren't they? It's not just the individual who we focus on. It's the fact the individual is receiving care within an environment which it will have its own um, atmosphere, its own approaches, and you bring the whole thing forward by doing that. And how do you capture? How do you capture based on the experience of the treatment itself? What's helping the patient and the healthcare professional to deliver in their care? Just to go back then to your comment about that, you're absolutely right, Andre. And actually, I think one of the challenges for us, in terms of how we talk as healthcare professionals, in terms of healthcare professionals delivering and supporting patients' care needs, is we have to move away from a doctor-centric role focus. And I've just fallen back into that now and see ourselves as we're a broader group of healthcare professionals who have all got our individual areas of expertise and have different time and contact with the patients. And certainly, if you look at dialysis units, I mean, the large burden of contact and care is with our nursing colleagues in that space, and they have to be prime movers in there. We have a great advocate in the UK, Nick Anderson, who worked with me in Birmingham, and Nick's pretty well known. Some people may have heard her talk internationally now, and Nick's a really high quality, was an outstanding clinical nurse who took her observations clinically to do a PhD in patient-reported outcome measures and then really lead in terms of the development of these particular tools, keeping a very tight focus on the needs of the patient.
Yeah.
So, it's one thing I'm really minded on that we may want to think about, and you'll have some thoughts on this as well, is how then you bring this together so that how do we put the symptom with the intervention? And you could think about examples of that. If a patient's has got a problem with itch, and we know we've got interventions around that. How do we bring that together in a way that we describe that with the biochemistry and we describe the interventions? And how do we use that to empower the patient who's often in a situation where they've got, there's a whole bunch of meds, there's the commitment to the treatment, and that area of their life we should be keeping it as ring fenced as possible, because we want them to live their lives outside of them. Our job as healthcare professionals is to keep them as safe in that care as possible and support them as much as possible so that it's not dominating their life and they live in their lives. But how do we describe the intervention around the symptom? And you can think about that. How sleep disturbance is one, fatigue, pain as it relates to mineral bone disorder with chronic kidney disease, itching as it relates to hyperphosphatemia, the interventions that we've got. How do we bring that all back together in the round? Because for me, that's should be one of the massive benefits of patient-reported outcome measurements, because it gives us all a far more global and holistic view of the interaction between what we can intervene around and what is truly important to the patient. I think that's an area in which, and that I think is where us enthusiasts can really sell this to our colleagues.
Great. Thank you. I think you've offered a lot to think about, a lot of also pointers where we can start off working on something. And one thing I just wanted to comment on quickly before we go to the last question is I think the key thing is also changing your language, which is we're used to enter the consultation room with a list of symptoms we want to ask about. Do you have dyspnea? Do you have irregular bowel movements and whatnot? While perhaps we might want to use a different language that asks about something else, what may be more important is, how do you think you're doing? Or what are the things that you would want to do and you're not doing? And what would you want to be better in your life, generally speaking? Maybe that's the entrance to that conversation, a different kind of question, a different kind of language.
Yeah, I agree with you, Andre. And if you've got a measurement tool, if you're using a patient-reported outcome measurement tool in routine clinical practice, you're supporting the patient to be able to capture that, to capture the change with time. In a way that we currently don't do. Really, we're not able to measure a lot of patient outcomes are framed as qualitative. It's there or it's not there. But in fact, we've got better and better at quantitating it. And I think using quantitative measurement within our tools going forward will be incredibly supportive of that, to allow people to step back and identify what's getting better for them,
Yeah.
what's getting worse for them.
Yeah.
There's a lot of noise, isn't there? And quite often we lose the thread on where we actually are
Yeah.
moving in the right direction or moving in a direction we wouldn't want to be going in.
Well, thank you for working on this, putting all the work in. I hope we get to hear more from you and from people who are enthusiasts at congresses. I think we need to talk about this a little bit more. And for the final question, we want to get a little bit personal. I hope you don't mind. It's not too personal. We just want to get to know our guests a little bit, and we're asking everybody, including you, which book, two songs, and luxury item would you take to a desert island?
Book and two songs and a luxury.
Yeah, exactly.
Yeah. Um, I, so I think book-wise, we've got to be. I'm not going to talk too much about. We're not going to talk about politics, but it's a political
No.
book I'd actually choose, which I'm cheating. It's a group of books. So it's a life and times of Lyndon B. Johnson by Robert Caro, which is
Oh,
which is a wonderful read, which just captures both a very interested man, but actually captures the detail of development of the hill country in Texas through to politics, the huge change that was seen in the US over a 40-year period. And there's so much. It's beautifully written and extraordinarily researched, and is a lifetime, is a true lifetime of work. I mean, Kara's in his late 80s now, I think, and we're hoping that we're going to see the last volume of that come out very soon. So that would be the book. I guess did you say two songs?
two songs. Yes,
Two
exactly.
songs. Oh God.
Yeah.
So yeah, I'm probably going to cheat a little bit, but Van Morrison, "Listen to the Lion," which is I encourage people go and have a listen to it, and it stands up by itself. And then I choose anything from "Kind of Blue," actually, by Miles Davis.
Oh, yeah, for
That
sure.
great
That
quintet.
would work.
Yes, it'd be
Yeah.
something in there. And Luxury Island, I hope you're going to send me somewhere that's, got some mountains. So I'd probably my luxury item would be my specialized Ethos road bike. So
Oh, okay.
I can get out on the roads and do some serious biking.
Yeah, I can. I'm not a big biker, but my country has gone bike crazy ever since our cyclists have been really good. But I really appreciate you mentioning that book series. I'm also not a big fan of political books, I would say, but one that I really enjoyed was a biography of George Marshall. It's called The Defender of the Republic. And he was a phenomenal figure, and learning about his life and his ways, and of course, the Second World War, the Marshall Plan, everything. It was very interesting. I highly recommend that as well.
Oh, I'll go and read that, Andre. Thanks for the recommendation. I've not
Yeah,
read it. I will
thank
read
you
it.
for yours. So, thank you, Paul, for sharing this with us. It's really something we need to look into. And thank you for joining us in A Pinch of Salt.
Pleasure. Thank you, Andre.